Hello, and thank you for listening to this training video. I'm Peggy.
And I'm Pranay.
We're both graduating fourth years who have volunteered with the titration program for the past 3 years, and we wanted to make a recorded version of the training presentation so that you guys could review it at home, both before the in-person training and then again anytime after the training that you need a refresher.
The three main things to take away from this video are as follows. What are the different types of insulin regimens used to manage diabetes? How do we use the insulin titration protocol? And when do you seek help from a more experienced clinician at the clinic?
In order to understand how we manage diabetes with pharmacologic insulin, it helps to review how the human pancreas secretes insulin throughout the day. We know that many of you haven't had EndoRepro yet, so this might be less of a review and more of just a crash course in insulin. And so one thing that we really want to emphasize is that it's completely okay to find the whole process of insulin titration a little overwhelming at first and to ask for help. I personally asked for help with almost every patient I had when I first started as a first year, and that's totally okay. We really want you to feel comfortable with what you're instructing patients to do, and we promise that over time you will.
Okay, so let's get started. At the most basic level, your pancreas secretes insulin at a low baseline level throughout the day, regardless of when or what you've eaten. This is because glucose is also being released into our blood at a slow rate thanks to processes like gluconeogenesis or glycogen breakdown in the liver. We call this low background rate of insulin secretion basal insulin secretion. However, sometimes you eat. When you eat, your blood sugar increases sharply and your pancreas releases insulin so that your body can utilize that sugar and put it away. We call this a bolus of insulin, which just means an amount that's released more quickly as opposed to the baseline rate. You can see here that this person's pancreas produces more insulin in the couple of hours that follow breakfast, lunch, and dinner. The amount and rate at which your blood sugar rises, and thus the size of the insulin spike, depends upon several factors, but some of the most important ones are how much you've eaten and what you've eaten. Eating simple sugars will cause your blood sugar to rise more quickly than complex carbohydrates, proteins, or fats.
So to summarize, over the course of the day, your pancreas releases insulin at a basal rate, even when you sleep, and then it also releases boluses of insulin throughout the day when you eat. In patients with diabetes, the pancreas actually loses its ability to function in this way. Or it's still making some insulin, but it can't make enough insulin to keep up with the body's demands and insulin resistance. So for our patients on insulin therapy, we want to mimic these natural fluctuations in insulin level. In order to simulate the pancreas's basal secretion of insulin, we use long-acting forms of insulin. There are several types of long-acting insulin on the market, but the two we use most commonly at the Free Clinic are insulin glargine, which is commonly known by its brand name Lantus, and then NPH insulin. Lantus, or glargine, is a type of long-acting insulin that's typically dosed only once a day. It lasts in the body for close to 24 hours at a pretty constant level. Thus, it's sometimes also called peakless insulin. Most patients take it at night after dinner. However, some of our patients at the Free Clinic are on quite large doses of Lantus, and so they will actually break up their Lantus dose and take it twice per day, typically in the morning and at night, although for people on a more standard dose, it is typically dosed once per day. The other long-acting insulin that we use at the Free Clinic is NPH insulin. NPH is typically taken twice per day in the morning and in the evening. And as you can see in the picture, the level of NPH in the body is a little less constant than it is with Lantus, but it still does a pretty good job of mimicking the baseline insulin secretion of a normal pancreas. One important thing to note about NPH is that it's less expensive than Lantus, and so more and more of our Free Clinic patients are actually transitioning to using NPH. A benefit of NPH is actually that because it is dosed twice per day, that if you have a patient where their blood sugar tends to run higher during the daytime hours than at night, or vice versa, you can adjust the corresponding dosing to compensate for that. So for example, if you have a patient whose blood sugar is persistently higher during the daytime hours, and then when they measure it in the evening, you could increase only their morning dose of NPH, or you could do a bigger increase in the morning than you do with the nighttime dose.
Some patients are able to achieve good blood sugar control with only a long-acting insulin. However, over time, patients lose their ability to sharply increase their insulin after eating. So, to achieve better control and more closely mimic the normal pancreas, we can add fast-acting insulin taken at meal times. These insulins take action quickly and typically last for a few hours after the meal. Some of our patients take the same dose of short-acting with every meal. Others measure their blood sugar before each meal and adjust their short-acting dose accordingly. taking a larger dose if the pre-meal blood sugar is higher or if they're consuming a larger amount of carbohydrates in that meal. And this is what is called sliding scale insulin. When I first started out, I had no idea what that meant. Again, you won't be adjusting patients' short-acting insulin, especially at first, but it is important to have a basic idea of how it works. So here we've got an example of how you can combine Lantus and a short-acting insulin to closely mimic the activity of a healthy pancreas. The GLAR gene is maintaining that basal rate that we talked about, and we're adding the boluses of insulin with the fast-acting insulin. And as you see here, the same thing can be done with NPH.
So before we move on to talking about the titration protocol, here's just a quick review of the types of insulin we use at the Free Clinic. It's important to note that there are a lot of other types of insulin out there on the market, but these are the ones that we really felt that you should get familiar with first because they're the ones that the majority of your patients are going to be using. So Lantus, or GLAR gene is the generic name, but at the Free Clinic almost everybody calls it Lantus, and that's what your patients are going to know it as, is the longest acting insulin. It's the peakless insulin that lasts up to 24 hours after taking just a single dose. Most patients take a single dose in the evening. Some of our patients who are on a very high dose will take it twice per day. NPH is the other long-acting insulin that we use. It's technically more of an intermediate-acting insulin because it lasts for most patients between 10 and 12 hours, and patients who are on NPH will take it twice per day. Lastly, we have the short-acting insulins, insulin aspart or Novolog, insulin Lispro or Humalog. These are both fast-acting insulins. They're both taken at meal times to account for the sugar or calories in general eaten at that meal, and they typically last 3 to 6 hours. The differences between Novolog and Humalog are pretty minor, and at this point, you should really just think of them as both being the same thing, both being fast-acting insulins. Okay, here is the insulin titration protocol that we use at the Free Clinic. There's a lot of information on this slide, so we definitely don't expect you to memorize the protocol. It'll be easily available to you when you're volunteering. It's posted on the wall in our volunteer rooms, and there will be a copy in each of the team's binders as well. So we really just want you guys to get familiar with this and highlight a couple of important things. For returning volunteers, this is a good time to pay attention because some of the things we want to highlight are actually changes from the protocol that we've used in the past.
Alright, so let's dive into this. For one, the suggested changes in the total basal insulin dosage are just that, they're suggestions. For example, for an average blood glucose of 140 to 179, you can increase by up to 4 units. If your patient's average is only 141, or if the patient is hesitant about increasing insulin, you may choose 2 units. On the other hand, if the average is 179, and the patient's totally willing, it might be wiser to go up by 4 units. You can also check the chart to see how your patient has responded to dose changes in the past, or ask the patient. Some people are more sensitive to insulin than others and require slower dose adjustment. One change from our previous protocol is that we are now actively reducing the insulin dosage for patients with averages from 80 to 100 mg per deciliter. These patients can usually maintain good control on less insulin, which can benefit them in many ways, including making weight loss easier, making hypoglycemia less likely, and we have had a few patients who've been able to reduce their dose significantly through exercise and good lifestyle changes, and one guy actually got off insulin entirely. It's also important to note here, for extreme hypo or hyperglycemia, you need to do more than adjust the dose. This might mean contacting a diabetes educator, Chris Worsham, who is a clinic coordinator, or the endocrinologist on call that day. And you can make an appointment for the patient, and sometimes you may even have to refer the patient to the emergency department.
Okay, now that we've taken a look at the protocol, here's a quick insulin titration example to work through. You have a patient named Mr. X who's taken insulin for his diabetes for the last 2 years. He takes 15 units of NPH insulin twice daily, and you'll note the abbreviation of their BID means twice daily is very commonly used at the Free Clinic. So here are his readings that he's taken for the last week at right before breakfast and then again before dinner. So if you want, you can go ahead and pause the presentation now while you calculate the morning and evening averages. So we've gone ahead and calculated the averages for Mr. X. You can see that his average of his morning readings is 147, and the average of his evening pre-dinner readings is 175. So according to the protocol, we can see that both his morning average and his evening average fall into the 140 to 179 milligrams per deciliter category. So the protocol recommends increasing his total daily basal insulin by up to 4 units. It's important to note that this increase is for the whole day. So if he was a patient who was taking Lantus, he was only taking 1 dose per day, you would just increase that dose by 4 units. But because he's on NPH, you're going to need to distribute those total 4 units that you want to increase over both of his doses, his morning dose and his evening dose. Typically, we'll just divide that increase evenly. So it would be add 2 units to the morning dose, add 2 units to the evening dose. But in this case, you actually noted that Mr. X's evening readings tended to be higher than his morning readings, which suggests that he needs more basal insulin during the day than he does at night. So you might actually consider distributing the increase in NPH according to those differences and not equally. So for example, instead of increasing from 15 units twice daily to 17 units twice daily, you could instead try giving him 18 units in the morning to account for the daytime hours when he seems to need a bit more basal insulin, and then giving only 16 units at night. And this is actually a really common pattern for our patients, having higher pre-dinner readings than morning readings. And we particularly see it in those patients who don't take any short-acting insulin to cover for meals. They'll sometimes need a little bit more basal insulin during the day.
The last major topic we want to discuss is the situations in which you need to get help managing your patients. Again, we want to stress that you can always get help, and you should, if you're unsure about anything or have questions. In those cases, you can ask a senior student on your team leader, a diabetes educator, Chris Worsham, or a physician for help. However, there are some special situations in which you need to contact either a diabetes educator or a physician, or in some cases, both. The most important and potentially emergent of these situations is a patient who is having significant hyperglycemia or hypoglycemia. Hyperglycemia, or high blood sugar, can occasionally represent DKA, diabetic ketoacidosis, or more commonly, a hyperosmolar hyperglycemic state, because type 2 diabetes patients don't usually get DKA, they get HHS. If the patient's blood sugar is above 300, make sure to ask if they've been having increased thirst or hunger, increased urination, blurry vision, nausea, vomiting, or abdominal pain. If the patient is experiencing any of these symptoms, contact the patient care manager, who is Chris Worsham, one of the diabetes educators, or one of the physicians in the clinic. The patient may need to go to the ER for treatment, which will likely involve fluids and then an insulin drip.
Hypoglycemia, or low blood sugar, can actually be even more dangerous than high blood sugar. Patients can become unconscious and even die when their blood sugar is too low. So if your patient has any single reading, so not an average, but any single reading of 60 milligrams per deciliter or less, this is really cause for concern. And one thing that you need to do if you have a patient who reports a very low reading like that is try to figure out if there's a reason that either you can identify or the patient can identify as to why that happened. Hypoglycemia can be triggered by a lot of things. It can be triggered by skipping meals, just eating less than usual, exercising more than usual. The last two in combination can often really do it. And of course, sometimes patients will inadvertently take the wrong amount of insulin, or they'll take a double dose without meaning to. So if you can identify a reason why the low blood sugar happened, that's reassuring. But you still want to go ahead and follow the advice of the protocol by notifying Chris. And if she agrees, you may wind up reducing the patient's dose by up to 20%, or making an appointment for the patient to see endocrinology. But what we really worry about is unexplained hypoglycemia. It's more concerning, and absolutely you need to talk to Chris or talk to one of the diabetes educators or physicians that evening. You're probably going to wind up reducing the patient's dose by quite a bit and having them come into clinic quickly. And Pranay had mentioned some of the symptoms of hyperglycemia. For hypoglycemia, a lot of times patients they can feel dizzy, they can just feel off, they say they don't feel right, they feel like their thinking is fuzzy. But importantly, some patients have what we call hypoglycemic unawareness, which means that they actually don't know. They don't have any symptoms that warn them if their blood sugar is really low. So if you have a patient with hypoglycemic unawareness, they will probably know that from past events, but you just want to keep an extra eye on those patients and make sure they really don't have any low readings. So there are a couple of other less acute situations where we also want you to still notify a physician or a diabetes educator. One of these is if you have a patient where your team has really been persistently increasing their insulin dose in response to high blood sugar, but their averages remain high despite the dose increases. So if you see that happening for 3 or more weeks in a row, please go ahead and notify someone. And the last thing, which is a little more subtle, is if the patient's basal insulin winds up being more than 2/3 of the daily insulin regimen, things can get a little bit off. Some of our patients are on both a long-acting and short-acting insulin. So if we are only managing their long-acting insulin. So if you have a patient where their sugars are running very high and your team continues to every week increase their long-acting insulin, over time things are going to get out of proportion and they will be getting too high a percentage of their total daily insulin from long-acting sources. In general, we like for the long-acting insulin to be not more than 2/3 of the total daily dose. So for example, if you have a patient who's taking 15 units of Novolog daily, they probably shouldn't be taking more than 30 units of Lantus or whatever their long-acting is. That's just a rough rule, but if your patient has exceeded the 2/3 threshold, go ahead and contact one of the endocrinologists or diabetes educators to just discuss that and make sure it's okay. Okay, so that is the end of the training video. We hope you guys found it useful. And we would really love to hear if you have any feedback about the video or how it could be more useful for you or future volunteers in the future. So if you have any feedback, please go ahead and let us know. Those are our email addresses up there. And you can also feel free to email us if you have questions about the titration program in general or how things work. We should note that we are both going to be interns next year, so if you have a pressing question, it might be faster to email your team leader or Chris or someone who's still at the free clinic, but we are more than welcome. We're more than happy to answer questions as well.
So this is the time for thank yous, and firstly, a big thank you to Dr. Li, who's a professor at the UBA Department of Pharmacology, and some of the slides in our presentations were adapted from the talk that he gave us in our second year of medical school. And we also want to thank the wonderful providers and the diabetes educators at the CFC for teaching us so much of what we know about diabetes and just in general how to be a compassionate physician. And we really hope that you have a similarly awesome experience at the titration program and go on to be amazing physicians. And thank you for listening to our talk.